Hi everyone, very good evening, guys. I hope I'm audible and visible to all of you, and I'm very sorry for the 7-minute delay. There was a little connectivity issue, but I really hope that now, once we are connected, it is seeming all fine and everyone's okay with the AV. There's no issue, and a quick thumbs up would, sort that as well. So I'm just waiting for that confirmation, and then we'll start right away. All of you are aware of the pathology revision, path micro revision that we are ongoing, and today we have a few questions on immunity that we are going to do. Acha, so everyone says that all's fine except for Dr. Anshum Ali, who says that volume में problem hai. Anyone who has any issue with the audio hai, or am I just visible and everyone's waiting for the audio right now? Is the AV both audio video both good? Yes. Okay, so yes guys, so we'll start with the revision. We have very few questions immunity के ऊपर है, so you know a couple of things that you have to revise. And how are we going to do the revision of immunity is going to be in two steps. So first listen to the two steps that we have. First, we'll have a revision of MCQs right now. So this is one step of revision. The second step of revision is going to be in the form of flashcards, and this will be on Telegram. So I always believe that you have to do certain things are more of ratta, and ratta is something that how many number of times I tell you, till the time you don't sit and write it or revise it on your own, you're not going to probably get that final confidence of it. So we are going to have a few flashcards. I'll be posting certain blank flashcards, fill in the blanks kind of flashcard on Telegram. That will be tomorrow. Okay, so today to we'll have this class anyway. Tomorrow I'll be posting approximately 5 or 6 blank flashcards. First, you will be doing a mental fill in the blanks in those, and then I'll be posting the solved version of it and the filled up version of that flashcard as well. Yes, so that is tomorrow, and पहले आज हम MCQs कर लेते हैं. That's the two-step revision that we are going to do. Right, so let's begin. Dr. Vidhi, you can put up your username and I can note it and help you with the same at the end of the class. Okay, so yes, everyone who's having a problem with the volume, please refresh, just quickly leave the link, rejoin, and most likely it should be sorted. Else, kuch bhi nahi kaam kar raha, then headphones would be the last option. But the maximum volume that the software and I can also commit to is this. After that, you'll have to probably resort to headphones if there is any issue still pertinent. Okay, chalo, let's begin. And before I begin, coming Sunday, I hope everyone is ready for the AIMT. Coming Sunday morning 9 o'clock with the All India Rank Predictor, especially for the NEET PG pattern, NEET PG 2022. And I hope you guys have enrolled. It's free for all, so please make benefit out of it. Okay, so yeah, let's begin. Question number one that I want all of you to quickly attempt out here is this. You have to find the incorrect match over here with regard to the type of amyloid, one of the most important topics that you have in immunity, regard to amyloid. So, yes, what is the answer to this question? And expected, wherever I put a star, much expected question. Most of you got it right, as okay, some say C and some say D, but I go with the majority of you. So you are right that with Alzheimer's disease, it is not A beta 2. With Alzheimer's disease, the type of amyloid is going to be A beta type of amyloid, not A beta 2. And the others seem to be fine. We'll be doing a revision also. One more question I want all of you to learn. So जिन ने D बोला था, you guys are on track. You've got the right answer. Give me one more answer and then we'll do that entire table once again. Here you have a 54-year-old male who's come to you as a case of renal failure and on dialysis. And then few months later, he presents with wrist joint pain, which is the type of amyloid deposition that describes the phenomenon. Perfect. So that is going to be answer quickly A, B, C, D. Most of you get it right again. That is A beta 2. So that's always a source of confusion, right? And I hope you guys remember the mnemonic. One is A beta amyloid, one is A beta 2 type of amyloid. When I talk about A beta amyloid, one brain obviously, and A beta 2, two kidneys. So one brain, so one beta, brain matlab Alzheimer's disease. When I'm talking about brain, I'm talking about Alzheimer's disease, one brain, one beta. When I'm talking about kidney, I'm talking about hemodialysis. And hemodialysis, kidney, two kidneys, A beta 2. That's the easiest way of learning it, which means one of the flashcards you guys are going to fill in the blank right now only. You're going to tell me all the amyloids related to this, a must revision table that you have to do. Quickly, we'll do it. Sabse pehle, let's begin with the easiest one, multiple myeloma. What is the type of amyloid that we have for multiple myeloma? So A everywhere I'll be writing for amyloid. A alphabet over here everywhere will be for amyloid. All the others you are supposed to tell me. Okay, so over here, perfect. For multiple myeloma, we have AL. What does L stand for? So A everywhere for amyloid, L over here will stand for light chain, because I know multiple myeloma is a plasma cell problem, right? So light chains बहुत ज़्यादा बनती है. There are lots and lots of light chains that are formed. As a result, AL type of amyloid. Very, very good. Now let's come to these two which are in front of you. This you can fill up very easily. Hemodialysis. I'm talking about two kidneys. I'm talking about two kidneys means A beta 2 type of amyloid. Alzheimer's disease, I'm talking about one brain. One brain will tell me I'm dealing with A beta type of amyloid. So these three are easily done. अब पहले तीन पे आते हैं. Let's pick up these. Let's pick up these. What did you analyze out of it? Did you analyze chronic inflammation, cancers, and familial Mediterranean fever? All of them have the same type of amyloid. Means whenever someone has a long-term inflammation, chronic inflammation, like pick up any inflammation of your choice, chronic pancreatitis, chronic osteomyelitis, something that is chronic. Something that is chronic. Second, when I'm dealing with cancers, for cancers, for example, I say renal cell carcinoma, Hodgkin's lymphoma, or someone has a familial Mediterranean fever, all of you are right. In all of these situations, A type of amyloid is what is going to be there. Done. Now let's come to the only thyroid cancer which has amyloid. The only thyroid cancer with amyloid is medullary carcinoma. And what is that amyloid? I think everyone knows. ACAL, because medullary carcinoma shows you what? It shows you calcitonin. My very small tiny little request to all of you before I proceed with the rest of this table, in the exam, because your exam going, you are always in a hurry and you never read what medullary has been asked to me. Please remember, there is a medullary carcinoma in the thyroid, which is totally separate. Where else do you study medullary carcinoma? There's a medullary carcinoma that also occurs in the breast, which is again totally separate. Then there is a medullary carcinoma that also happens in the kidney, which is again a third separate entity. Please do not get confused in the exam when they are talking about all of this. And I want to take this opportunity and actually tell you and revise with you all the MCQs that come with these medullaries. I think the MCQ for medullary RCC I taught you yesterday, day before yesterday in the Kickstart morning session. What kind of thing, hematological disorder is this associated with? Medullary renal cell carcinoma. Very good. Everyone remembers? Sickle cell trait, excellent. Sickle cell trait patients में medullary RCC is there. That is the question that you get on this. Now let's talk about medullary carcinoma breast. Can you tell me, in breast, do we always study that classification? What kind is it? Is it luminal A, luminal B, triple negative? कहाँ कौन सी variety में जाता है? Medullary carcinoma breast over here. In the breast, it comes under the triple negative breast cancer. It is a triple negative breast cancer. I have always given you a mnemonic. Triple negative. Whenever they are wanting to ask you the negative breast cancers, NE, you will always pick up the ME wala. So medullary carcinoma is negative, triple negative breast cancer. One more question comes on medullary carcinoma breast. Any kind of inflammation which is very, very common in this cancer? An all-time favorite NEET PG question. Any kind of inflammation. It is lymphoplasmacytic inflammation. Please remember. Very famous question again. Two things. Medullary carcinoma breast is a triple negative breast cancer and it shows you lymphoplasmacytic infiltrate. Very important. Now coming to medullary carcinoma of the thyroid. Here I told you that you have to learn a tumor marker. What tumor marker is there? The tumor marker that we have is calcitonin. And when we talk about calcitonin, what kind of amyloid will it deposit as? It will deposit in the form of A cal, and that is exactly what I was asking you over here. In fact, now that you have mentioned everything so nicely as I was seeing all your answers, then one question I've got, luminal A is also triple negative. Nahi, luminal A is a totally different variety. There are four varieties, na? Luminal A is separate, luminal B is separate, triple negative is separate. These are all three, four very different entities. This is not the same. Okay, coming back. Can you tell me the genetics of medullary carcinoma thyroid? Very famous genetics, and there's a rhyme also that we have learned for it. Have we studied something called RET10 med men? What is RET10 med men? Very simple. What is the gene that is altered over here? It is the RET gene mutation. Red gene is on which chromosome? Red gene is present on chromosome number 10. What is the cancer that I'm talking about? I'm talking about medullary carcinoma. And what is the syndrome with which it will be associated? MEN2A, MEN2B. So now comes the next thing, that is RET 10 med men. So RET is gene, 10 is the chromosome, med is the tumor, men is the syndrome. So this RET10 med men is applicable to which kind of medullary carcinoma? Thyroid wala medullary carcinoma. I hope this is okay, and you in the exam take home message, do not just read medullary of which organ has been asked to us. Now coming back, here I asked you medullary carcinoma thyroid, and ACAL is what you had to consider over here. Now let's go on to the remaining two. You want to add on something, guys? For systemic senile amyloidosis and for amyloid polyneuropathy, both of them happen to be the same type of amyloid, that is ATTR. ATTR, but there's a difference. And what is the difference? Very good. In systemic senile amyloidosis, it is actually an increase in the quantity of this protein. Whereas in polyneuropathy, it is a mutation of the protein. How did we learn this? कि किसमें ATTR का quantity problem है, किसमें mutation problem है. So systemic senile means old age, too much of age. Quantity wise, too much of age. So ATT wise, too much of quantity. Here I'm talking about the quantity of the age. Here I'm talking about the quantity of TTR. Whereas when I talk about polyneuropathy, N for neuropathy, N and M happen to be neighbors. So neuropathy wala is associated with mutation. N and M, neuropathy wala is associated with mutation, and over here quantity of age, old age, quantity of TTR is how we learn. Now if I get back, so this is your final chart. I've already filled it up for you. This is your final chart, and when I get back to this question now, I think it's very simple that when I'm dealing with chronic inflammation, it is AA type of amyloid. Same for familial Mediterranean fever is AA type of amyloid. Polyneuropathy, ATTR, कौन सा वाला ATTR? Quantity वाला ATTR या फिर mutation वाला? So NM. You will say, ma'am, this is the mutant wala ATTR that we have. And lastly, Alzheimer's disease, it is not A beta 2, Alzheimer's one brain, it is A beta. And similarly, the next question is also there. Achha, some people in between are randomly asking me for crash course dates. I don't know which crash course are you referring to, because we are having a crash course for NEET already. If you're asking me for FMG, then that is also decided after 20th of April. So any other third crash course that you wish to know, then type it out in the end. Abhi, again, one more crash course date. So, कौन सा crash course ढूंढ रहे हो? Please let me know, then I'll be able to help you. And in the end, we'll discuss. अभी पहले half an hour, let's just sit and study, right? Okay. So having said that, here also this question was sorted ना. इस question में ऐसा कुछ fancy नहीं था. Hemodialysis था, kidney था, A beta 2 type of amyloid is going to be there. Now my next question from this question only that I'll ask you. If this patient, this same patient who's 54 years old, he had kidney failure, he's on hemodialysis, he started showing you deposition of A beta 2 amyloid. Which renal cell carcinoma is he at a risk of? Hemodialysis patients are at a further risk of which renal cell carcinoma? I hope you remember dialysis, dad, papa, that is how we had learned it. Dialysis, dad, papa means papa matlab papillary RCC. So which RCC is there with the risk of dialysis? Dialysis से किसका risk है? Papillary RCC का risk है. That is one question that you can get. Second question that you can get. Same patient. See again, same 54-year-old patient. Same he's on dialysis. Same he has shown you A beta 2 type of amyloid. But in which organ does this most commonly get affected? So where does it deposit this A beta 2 amyloid? सबसे ज़्यादा कौन से organ में जाता है? It goes into the joints. Most commonly wrist joint. And anyone who can analyze why not maybe the liver and the kidney? Why am I saying wrist joint? Because that is primarily where the cannula is. जो hemodialysis के लिए obviously cannula लगता है ना, so that all the blood can be filtered out. So the cannula is somewhere over here, and that is the reason that the maximum deposition of A beta 2 will also happen somewhere around the wrist. And when I say around the wrist, maybe all of you know that median nerve gets affected. Median nerve पे deposition होगा. So I know for a fact that carpal tunnel syndrome is what the patient is at a risk of. So all these are associated questions that you can get. Hemodialysis, A beta 2 type of amyloid, wrist joint is affected, median nerve की वजह से carpal tunnel syndrome होगा. Finally, most grave complication that can occur is papillary RCC. I hope all of this is done. We can move on to the next question. That is this. Again, you have to find me the incorrect match with regard to the site of amyloid deposition. Okay, Dr. Anshumali has a very valid question before I start with here, that nowadays we either use central lines. For that matter, nowadays, even this A beta 2 is not seen, because nowadays your hemodialysis machines are so advanced that this beta 2 microglobulin is no longer a problem. So these used to be problems when old machines were being used. So these kind of problems were more in the past. Nowadays, you don't see too many patients because you've obviously got advanced machines, you've got advanced techniques. So these happen to be more of, you can say one step before the advancements came out. Okay. Acha, now coming back, find the incorrect match over here. Very well, everyone has given me a right answer right away. Perfect. So this is the, matlab, you had to find the wrong one. The wrong match is this. Liver में it's not in the canals of herring. Liver में कहाँ होता है? Liver में it is going to be in the space of Deci. So now we have to analyze that table next. अब अगला table जो हमें देखना है is to do with the deposition. Then we'll come back to this question. So this is the next one, guys. Now you have to tell me that when I have organs written in front of you, all of you will tell me the site in that organ where it's going to go. So let's start from here. Let's start from the kidney. Where in the kidney does it go? And we'll try to do some idhar udhar ka questions also, so that everything gets sorted. Very, very good. In the kidney, it is the mesangium. Now, what are the questions in kidney? Do you want to revise this, or अभी सिर्फ amyloid पे focus करना है? Do you want to do इधर उधर का questions? I personally feel कर लेना चाहिए, because exam going ना, so you need a little bit of cumulative and holistic kind of an approach. So I think personally we should do, and that will be a little more beneficial for us. So when I'm talking about mesangium, ठीक है? So when I'm talking about mesangium, we have what all questions? Number one, you'll say, ma'am, question number one that you can get is amyloid ka deposition is going to happen over here. Question number two, what are the cells in the mesangium? M for mesangium, mesangium of the kidney, M for mesangium. You'll say, ma'am, macrophages are there in the mesangium. In fact, when macrophages in the kidney, what is the name given to macrophages in the kidney? Macrophages in the kidney are known as the mesangial cells. Macrophages in the kidney, they are known as mesangial cells. So that's the next question that you will get. Coming to the third question, is there any nephritic syndrome where IgA gets deposited in the mesangium? That's the third question that you can get. IgA depositing in the mesangium, and yes, very good. That is IgA wale disorder. सोचो adults में कौन सा disorder है? You say, ma'am, I know of this. It is known as Berger's disease. It is known as Berger's disease, which you very famously also call as IgA nephropathy. So over there, please remember, where does it deposit? Where does IgA deposit? It deposits in the mesangium. So these three mesangium related questions are something which are very, very famous. And NEET PG students के लिए इतना information more than enough. Just in case you are targeting INI CET, gut feeling says that this time they might ask you something, because INICET मतलब aims and all कुछ extra out of syllabus तो होगा ना, that is like understood. So this time they can ask you the CD marker for a macrophage in general. Macrophage present anywhere in the body, from the brain to the kidney, macrophage is CD68 positive. I'm just telling you only for the INICET exam, it might come up this time. Otherwise, for NEET, this information is not important. Okay, तो mesangium related questions हो गए, and now we come back to kidney में mesangium में amyloid deposit होता है. Now coming to the next, in the heart, what is the site of deposition in the heart? Very good. In the heart, the deposition is going to be in the subendocardium. In the subendocardial region. Subendocardium. So below the endocardium. For that matter, even remember, in the blood vessels, the deposition is below the endothelium. So that is going to be subendothelial. Subendothelial. Now I have to ask you some miscellaneous questions also, right? तो इसके अंदर क्या पूछेंगे? They will ask you that in the heart, when amyloid will deposit in subendocardial, what problem happens in the heart? Which kind of cardiomyopathy happens in the heart? I saw one or two answers in the beginning. Very good. It was restrictive cardiomyopathy. Restrictive cardiomyopathy is what can happen. One of the most common causes of it is amyloid. Acha, now let's go to liver. Liver में it's evident, all of you have already told me. Liver में it's going to be the space of disease. So now my next question to you is, what all can happen in the space of disease, guys? That is the revision that we have to do. So when I talk about SOD, space of disease, question number 1, के liver में यहाँ पे amyloid deposit होता है. What are the cells present in the space of disease? Quickly, and I think everyone knows the answer to that question. There is some kind of cell which we call as Ito cells. Now I'll tell you the difference between Ito cells and stellate cells of the liver. So space of disease, very good, everyone's right कि मैम इसमें Ito cells हैं, stellate cells हैं, but I have written them with a slash. Basically I want to tell them that Ito cells and stellate cells same चीज है. So why am I saying that? In terms of calling them, yes, but I would say Ito cell is like, for example, you guys, when you have your exam after 1 year versus when you have an exam after 1 month, you are very different kind of people, na? You are the same person but you act differently. When you have an exam after 1 year, you are kind of chilled out, slowly you are studying. When you have an exam after 1 month, we are sitting over here and jaldi rapid crash courses are happening, but you are the same person acting differently, correct? So this is your Ito cell, your sleepy version, which knows अरे exam को अभी 1 साल बचा है. So all this is going to do, sit and eat and sleep. So all that this will do is store. This will do storage of vitamin A. This is going to sit and eat, अच्छे से खाओ, so relax करो. So Ito cell is that version of us when the exam is 1 year away. Storage of vitamin A is what it does. Stellate cells, nowadays all of us sitting in class today, we are all stellate cells, because now we are no longer sleeping, we've become very active, very rapid we've become. Means stellate cells are not going to sit and eat and store things, they are going to act. What do? They lay down fibrous tissue, they cause fibrosis. Fibrosis मतलब collagen deposition कराते हैं. So can you think of any disease in the liver where collagen deposition occurs? Collagen deposition occurs in, yes, collagen deposition occurs in cirrhosis of the liver, right? So finally, I can say that, ma'am, Ito cells and stellate cells are the same people. It's the same person. Ito cell is my sleepy version who's just sitting and eating, storing the vitamin A. Whereas stellate cell is the active version of it. That someone has stimulated it. Ab exam pass mein hai. I have to do more of work. So it will lay down a lot of collagen, and that is what it will result in cirrhosis of the liver. Stellate cells are not macrophages. Someone asked me in between, no, stellate and Ito cells are one. Macrophages of the liver are something else, na? Macrophages of the liver का तो एक दूसरा नाम है. There's a very famous name for macrophages of the liver known as Kupffer cells. So they are totally different. Nothing to do with this. They are totally different. Here I'm talking about Ito and stellate cells. They are the same. ठीक है, some of you are saying, ma'am, right now I am super stellate. ठीक है, you can become stellate pro max भी बन जाओ. That will also be acceptable. As you keep coming to nearer to the exam, you will become stellate pro max version of yourself, and that is good. That is what you ideally should be doing right now. ठीक है, coming back. Now we come back to the liver done. Now let's come to spleen. Spleen में we have two pulps. We have red pulp and we have white pulp. तो red pulp में क्या होगा? Red pulp में amyloid gets deposited. That is known as the lardaceous spleen. White pulp में it gets deposited and that is known as the sago spleen. So why not we do questions to do with red pulp and white pulp also? Yes, ये भी काफी important है. So what are the summary points of red pulp and white pulp that you have to know for the exam? And that is how ideally you should be studying right now, guys. By reading one table, you should be analyzing everything that you have studied regarding that. Okay, so one is spleen se related red pulp and white pulp question. My first question to you, the spleen has obviously it has involvement with the help of amyloid. I will not repeat that. So amyloid दोनों में जाता है and you've told me the names for it. How did you learn them? I hope you remember. Sago. Sago spleen is something, sago is sabudana. Sago is sabudana. Sabudana is a white color grain. So sago is a white color grain. So this is the white pulp involvement. Whereas when I talk about lardaceous spleen, students learn it as lal. They learn it as lal, that is nothing but red. So yes, lardaceous spleen is when there is red pulp involvement. Second question that you get in the exam. Where do all the leukemias, lymphomas occur? If I say leukemia, lymphoma हुआ है spleen में, तो कहाँ होगा? Red pulp में होगा, white pulp में होगा? That's the next question. So remember, all the leukemia, lymphomas, all the leukemias and the lymphomas are going to occur in the white pulp, and that kind of makes sense because leukemia hai, lymphoma hai, they are white blood cell disorders. They are white blood cell disorders. They should occur in the white pulp of the spleen, except, now this is where you get a question, except two of them. One of them is hairy cell leukemia. Hairy cell leukemia occurs in the red pulp of the spleen, and the other one is known as hepatosplenic lymphoma. Hepatosplenic lymphoma and hairy cell leukemia, they occur in the red pulp of the spleen. I hope these white pulp, red pulp kind of questions are okay with everyone. Yes, all good. वापस आ जाए. Coming back, this is also done. Skin में क्या होता है when amyloid, now coming back to amyloid, when amyloid gets deposited in the skin, you call it that ma'am purpura will develop, rash will develop, the skin has pinch purpura. Simple. If you pinch the patient, pinch the skin, purpura reddish हो जाएगा. So pinch purpura. Coming to the joints, I think we've already studied joints and carpal tunnel syndrome. I'm not going to repeat that. We've already done it. GIT. What happens to the size of the organs? Whenever it deposits in GIT, what happens to the size of the organs? Everything becomes big and fat. Means amyloid will deposit in it. Everything will become big and fat. There is going to be organomegaly that is going to take place. Organomegaly. Except one organ. Who will tell me that? The last collateral knowledge that you have to know for right now. All organs increase in size with amyloid except, excellent, kidney. Exception being kidney. Kidney is the organ that can shrink. Early stages में, later stages में. In the late stages of amyloidosis. So again, I want to tell you, if I'll directly tell you with questions, that's better now. If I say that when amyloid gets deposited, you have to tell me true or false, okay? When amyloid will get deposited, all the organs will increase in size. Is that a true statement or a false statement? So you'll say, ma'am, that's a true statement. Even kidney, if I say kidney also increases in size in the early stages, yes, in the early stages, including kidney, each and every organ becomes big and fat. Every organ shows organomegaly. Only in the late stages the kidney shrinks. Late stages of amyloid, kidney tends to shrink. This is the statement that you have to learn. So initially, all the organs without any exception, heart, liver, spleen, kidney, everything increases. That is what you have to know out here. And I think the table is also over for us. And with that, the question also made sense. Kidney mein definitely mesangium was correct. Heart में subendocardial was correct. Blood vessel subendothelial was correct. Liver में it was space of Deci, not canals of herring. So can you tell me what is there in canals of herring? Again a NEET PG question. What is there in the canals of herring, guys? Yes, canals of herring. में कोई बहुत famous cell है, I'll tell you there's something called the oval cell. There's something called the oval cell, and oval cell matlab perfect. Oval cells are the regenerative cells. These are the stem cells of the liver. So if someone asks you where are the stem cells of the liver located, they are going to be the oval cells. Those are in the canals of hair. Okay, if you've answered this, now you answer the next question. Here you go over here. Which of the following stains use ultraviolet light for the examination of amyloid? Which of the following stains use ultraviolet light for the examination of amyloid? Congo red, PAS, thioflavin T, Lugol iodine. Quick answer. Ratta question hai, no concept, mugging up kind of a question, and you guys are very good with it, I know. Okay, so it is thioflavin T. So let's do a very quick recap of all the stains also. Kya stains hote hain? I'm going to write it over here. I'll write the name of the stain. You tell me the property that you know about it. So सबसे पहले obviously the Congo red is something that comes to everyone's mind. The most important stain for amyloid, Congo red. Okay, so when I talk about Congo red, I can look at Congo red under two microscopes. I can look at it under light microscope, and the other one, very good, polarizing, great. The other one that I can look at it under is going to be the polarizing microscope. So under the light microscope, Congo red gives what color? Congo red gives a salmon pink or a red color. Whereas under polarizing microscope, instead of writing, I'll just make this. Does it give an apple green birefringence? Yes. So that is what it gives under polarizing microscope. So I hope these 2 points to begin with are okay. Under light microscope, it's going to give a salmon red color. Under polarizing, very, very important question, which microscope? Polarizing microscope, apple green birefringence. अच्छा, और क्या क्या stains हैं? Congo red definitely stain है. PAS is also a stain, regular light microscope stain. Thioflavin T is also a stain, but the problem is that thioflavin T is not a regular light microscope color stain. Thioflavin T uses ultraviolet light, and now think logically, ultraviolet light मतलब कौन सा microscope था? Which microscope uses ultraviolet light? I taught you in the last class only. Fluorescent microscope uses ultraviolet light. So if I want to use thioflavin T and I'm using ultraviolet light, the kind of microscope that I'll have to have in my setup will be the fluorescent microscope. Is that okay with everyone? इसी के continuation में today we are doing all इधर उधर का questions also ना, as we go nearer to the exam. So we also have to understand what else in pathology is Congo red positive. That is the idhar udhar ka question that we have. Tell me guys, what are the things that you guys know of which are Congo red positive in pathology? One I will answer for you, that is amyloid, and the others you answer for me. At least two more so you should tell me. Two more you have to tell me things which are Congo red positive. Yes. One thing is in the brain. I'll give you one is brain, one is muscle. Big hint I've given you. Very good. I've got one answer right away even without a hint. Brain wala, everyone's heard of prion diseases. Prion diseases tend to affect the brain, right? So Kuru plaques. Kuru plaques tend to be Congo red positive. Brain wala disorder ho gaya. Basically we were talking about prion diseases. What is the muscle wala disorder? Muscle disorder, last thing, IBM. What is IBM? Inclusion body myositis. Inclusion body myositis is something which also is Congo red positive. So these are, again, I would say this would probably go more in favor of an INI-CET kind of a question. I'm giving you few fillers of INI-CET also because we are approaching that exam as well, right? So these are the three things which can be Congo red positive. Mug it up by heart. Another expected question for this time. And now I want to ask you one question from medicine point of view. This inclusion body myositis, if they have to give me a question on IBM, what is the age group and what is the muscle group that they will tell me? Age group क्या होगा? Young में होगा, old में होगा. IBM affects which kind of age? The young population or the elderly population? Point number one. This is the most common myositis in the elderly population. The most common myositis in the elderly population. And which group of muscles does it affect? Myositis, proximal or distal? Proximal or distal? Next question, last question from this slide. This tends to affect the distal group of muscles. Distal group of muscles. So everyone, yes, I think everyone's told me. So how have I learned? Inclusion body में सब कुछ दूर दूर है. एज कौन सा है? दूर वाला एज, ओल्ड एज वाला एज. एंड मसल कौन सा? डिस्टल वाला, नॉट प्रॉक्सिमल वाला, डिस्टल वाला. सो एंड वाला मसल्स, एंड वाला एज, दैट इज इंक्लूजन बॉडी मायोसाइटिस. एंड वाला एज, एंड वाला मसल्स. सो एल्डरली एज and distal muscle group, that is what is happening in IBM. And inclusion body, so they will ask you in inclusion body myositis, the inclusions that you see are positive for which stain? They are positive for Congo red. So other than a myeloid, everyone has done right. And now we come to this question: which of the following is not seen on electron microscopy? Because we have done light microscope, we have done fluorescent microscope. Now we need to know what is the appearance of electron microscope of a myeloid. Not seen. So first, everyone's giving me a right answer. 2-3 answers I've got and which seem to be right. Yes, but we'll still wait. Okay, amazing. Everyone knows the answer. Okay, so this is not seen. So first, let me analyze what is seen on the electron microscopy. A myeloid कैसा होता है? You'll say, ma'am, ऐसा दिखता है. Fiber, fiber, fiber. Line, line, line. Non-branching fibrils. See, I have not made any branch. Line, line, lines. So this is non-branching fibrils. Length, I don't know. No one can analyze the length. The length is going to be indefinite. So there's an indefinite length. But diameter is definite. What is the diameter? The diameter is 7.5 to 10 nanometers. This you will have to mug up. Don't ignore it. 7.5 to 10 nanometers is the diameter. So these three things, non-branching fibrils, I don't know the length, indefinite length, and 7.5 to 10 nanometers diameter, that is electron microscopy, not this beta pleated sheet. Beta pleated sheet configuration is not seen on electron microscopy. It is for a myeloid, but it is seen on which technique? This is how a myeloid is seen on X-ray crystallography. Please remember, on X-ray crystallography, which is not a very commonly performed technique either, more for MCQ purposes, but a myeloid on X-ray crystallography tends to be beta pleated in configuration. And all of you have definitely given me a right answer, so very, very good. Okay, now let's move on to the next question. Sudden switch of the topic also in a way that has happened. I think 2-3 more questions are left, so quickly let's analyze those as well. Here we have a male patient who presented with an eczematous rash over the body along with repeated bleeding episodes and repeated infections. On peripheral smear examination, there are small sized platelets which are found. What is the diagnosis? And C, okay, was Wiskott-Aldrich syndrome. Acha, so before I get into Wiskott-Aldrich syndrome, all of you need to tell me Wiskott-Aldrich syndrome, if I would have asked you from genetics point of view, what is the inheritance of Wiskott-Aldrich syndrome? Question number 1, what is the inheritance of Wiskott-Aldrich syndrome? Inheritance, Wiskott-Aldrich syndrome. X-linked कुछ है. Now you tell me X-linked what? Dominant or recessive? It is XLR. Yes, okay, it is X-linked recessive. Some of you said autosomal recessive. No. So there's a chota sa homework for all of you that you're going to do, because next time I'm also going to give you some targets for genetics only. That is why I've given you this right over here. X-linked recessive का एक mnemonic था. What was the mnemonic? Do we all remember? There is a mnemonic for the XLR disorders, and that mnemonic goes as Ys A B C D E F G H. कुछ याद आया? This was the mnemonic for XLR disorders, and the Ys over there used to stand for Wiskott-Aldrich syndrome. So XLR is the inheritance for Wiskott-Aldrich syndrome. And now why did I ask you that? X-linked recessive disorders. The disease occurs more commonly in which gender? More commonly diseased are the male population. That is the concept of XLR, and that is how my question also started. The question was mentioning a male over here because in XLR disorders, disease usually happens in males. And what are females? Females usually tend to be carriers. Females are usually the carrier population, right? ठीक है, तो पहले gender wise I am sorted. Over here it's a male. After that, I call Wiskott-Aldrich syndrome as the bye-bye disorder, right? That is how we had learnt it. Was matlab past tense. Always and always. Bye-bye to the past. That is a life lesson also. Bye-bye to the past. So was, past tense, bye-bye कर दो. Bye-bye का क्या है? B for bleeding, I for infections, and E for eczematous rash. Repeating, bleeding, infections, and eczematous rash. That is what we have for Wiskott-Aldrich syndrome. And now they will ask you that, okay, there is bleeding, there is infection, there is eczematous rash. Out of this bye-bye disorder, why did the bleeding occur? So you'll say, I'm bleeding. Whenever word bleeding comes, the first cell that comes to my mind is platelet. So यहाँ पे platelet का problem हुआ होगा. Platelet count must have gone down. Platelet size must have gone down. So can I say that this disorder has small sized platelets? अब इधर उधर का question भी आएगा. We will be doing all the disorders with small and large platelets. But अभी के लिए the platelet size has gone down, right? So that was mentioned here also. This patient had small sized platelets, all of which is going very well in favor of Wiskott-Aldrich syndrome, which is an X-linked recessive disorder. The last question that you can get, if we have FMG students in class, FMG का तो ये favorite question है. Wiskott-Aldrich syndrome is their all-time favorite syndrome that they have. An immunoglobulin profile of that is asked. So yes, what is the immunoglobulin profile? The way you write Wiskott-Aldrich syndrome, invert the W. Invert the W. Invert means you are going to go in this direction. You will invert it, arrow going down. IgM is decreased. There's a decrease in IgM that we see. IgA and even E can be increased. IgA and A is as it is, no up, it's upright, right? No one's inverting it. So A and E can be increased, whereas other ones tend to be normal. So what is the most important thing? The most important thing is IgM is decreased, and that is a profile of Wiskott-Aldrich syndrome. Is that okay with everyone? Yes. इधर उधर का question कर ले. इधर उधर का question is the different platelet variations that I can see in the exam. So when they talk about platelet, first tell me 3 numerical questions on platelet. First, revise the normal count for me. The normal count of platelet is going to be 1.5 to 4.5 lakhs per mm cube. 1.5 to 4.5 lakhs per mm cube is the normal count. Number 2, if someone asks you what is the normal size, it is roughly 3 to 4 microns. 3 to 4 microns. Number 3, if someone asks you the lifespan of platelets, it is 7 to 10 days. These are 3 numerical things that you have to remember. Repeating, the count is 1.5 to 4.5 lakhs. Size is 3 to 4 microns. Can you say roughly RBC ka half hai? RBC is 7.2, right? And this is roughly coming out to be a half of RBC. That is how you learn it. And lifespan is 7 to 10 days. Okay, now I'm talking about the size parameter. Over here, I'm talking about size. So platelet में size से related दो चीजें. Either I can get small sized platelets or I can get large sized platelets, which you also call as giant platelets. You can also call them as giant platelets. So for small size platelets, what disease did we do right now? For small size platelets, we did Wiskott-Aldrich syndrome. For giant platelets, what all diseases come to your mind? What all diseases? Yes, this I want everyone to answer. So I'll start. पहले तो platelet का ही सोचो. Has everyone heard of ITP? Immune Thrombocytopenia. It's a platelet wala disorder that can show me giant platelets. ITP can show me giant platelets. Think of an AML, which is to do with platelet. Which AML involves platelets? It is AML M7. Platelet involving AML is AML M7, which everyone remembers. And I've also seen someone has written all the, the things which is there needed. Very good. You guys know the list. Now we have May-Heglin anomaly. Perfect. We have May-Heglin anomaly. Any syndrome? Yes, we have myelodysplastic syndrome. Perfect. And अब कुछ बचा Bernard-Soulier syndrome. Perfect. So what are the syndromes? Myelodysplastic syndrome, Bernard-Soulier syndrome, May-Heglin anomaly, ITP is anyway a platelet disorder. AML M7 is anyway a platelet disorder. So these are all the conditions out of which one question if I have to pick up, जो वो पूछते ही पूछते हैं, Bernard-Soulier syndrome. Always remember Bernard-Soulier syndrome shows you बड़ा platelet. Bernard-Soulier syndrome will show you bada big platelet. That is how you learn it, and all-time favorite question. I think you guys already know this, so I don't have to repeat. Coming back, small size ke liye Viscott-Aldrich, and that is what I was reading, which is pretty much done over here. Now I move on to the last question of the day, and CD40 ligand defect. Quick answer. This we revised in one of the CD markers wala class. Very, very good. CD40 ligand defect. Viscott-Aldrich, Seaweed, Skid, Hyper IgM. And I have already started getting answers, which obviously I was expecting a right one. Hyper IgM syndrome. They have asked about CD40 ligand defect. Now that is what I want all of you to revise with me. You will say, ma'am, there is something known as a CD40 receptor. And when there is a receptor, then you will say that there is something known as a CD40 ligand, right? CD40 receptor and CD40 ligand. CD40 receptor is present on which cell? Can you label the cells for me? Receptor is present on B cells. Ligand is present on T cells. कैसे याद करेंगे? Acha, before that, Dr. Akshay, actually, just sorry, break over here. You've asked me a query regarding small size. Small size platelets are also seen with X-linked disorders, autosomal recessive disorders, but those are never asked in the exam. Exam में सिर्फ Viscott-Aldrich syndrome पूछते हैं, so we limit ourselves to that. Okay? Acha, now coming back, CD40 receptor, the way you write R is the same way that you can make a B out of it. You can make a B out of it. So receptor is present on the B cell. Receptor is present on the B cell. Whereas the way you write ligand, L, is how you can make a T out of it. T भी ऐसे ही लिखते हैं. So where is the ligand present? The ligand is present on the T cell. So CD40 receptor on the B cell, CD40 ligand on the T cell. Here they said there is a CD40 ligand defect, means there was a T cell defect. Even if they would have said a CD40 receptor defect, even if this defect would have happened, the disease would have been the same. Hyper IgM syndrome, most common defect is the ligand defect. Second most common defect is the receptor defect. That is how you learn it. So ligand is the most common, receptor is the second most common. अब थोड़ा सा twist in the story कैसे आता है? You'll say, ma'am, what if in the exam they only write CD40? What do I consider? Do I consider this as the receptor or do I consider this as the ligand? If they say the cells are CD40 positive, I'll say please consider this as the receptor. If only CD40 is written, you will consider it as the receptor. You will consider it as the B cell, because what is CD40 ligand? Someone had mentioned, yes, 2-3 of you had mentioned, CD40 ligand is also known as CD154. Please remember, when they only write CD40, that automatically means CD40 receptor. Because if they'll want to specify ligand, either they will write CD40 ligand fully or they will write CD154. I hope that's okay with everyone. And that results in which syndrome? That results in hyper IgM syndrome. So means now when you look at a question, दो बहुत simple points है. If IgM is more, they are talking about hyper IgM syndrome, versus if they give you an immunoglobulin profile in which the IgM is less, which disease are they talking about? They are talking about Viscott-Aldrich syndrome. There the IgM was less, and in hyper IgM obviously the IgM is going to be more in quantity. I think with that we can definitely wrap up, but the story is not over. अब कल flashcard revision है. Flashcard revision tomorrow is on Telegram, not a video class. It's just some blank flashcards that I'll be posting. Mentally you guys will solve it. I'll give you 15 minutes to solve it, and after that I'll post the the proper solutions of that flashcard. So it will just be a very quick revision of all the immunodeficiency disorders. So that is something which you have as a practice session tomorrow on Telegram at 9:30. And yes, that's about it. And Dr. Abhinandini, yes, the flashcard will take care of skid wala question also. Don't worry about it. And two students, I think Dr. Vidhi and Dr. Akanksha, just help me with your username so that I can help in the unblocking process. Dr. Vidhi, I've noted yours. Dr. Akanksha, I'm still waiting for yours. Acha, one doubt about malaria class on Acridin Orange. is used in QBC. Yes, acridine orange is used in QBC. Dr. Akshay, in the morning session we discussed it. Acridine orange is used as a part of quantitative buffy coat in the capillary. This morning we were putting it up. If you have any other query, I'll see that. CD marker class, Dr. Bhargav, end of April. Every time end of the month I have one CD marker class for revisions. So this time also end of April we'll be having it. Next question, Dr. Kanksha, I've noted. And okay, does a myeloid have affinity to a specific substance? No, organ-wise affinity hota hai. So I've told you na that in multiple organs it can go to different locations specifically. First it goes to that location. Means like when I say in the kidney it goes to mesangium. First it goes to mesangium. After that it can gradually involve the entire kidney. All those areas that I was mentioning out here, if I show you that table again, all these areas that I was mentioning were the first sites to which it tends to go. After that it can, late stages it can involve the entire organ also, right? Okay, correct. So one class on renal path, don't worry Dr. Ashwarya, that is already in the timeline. It is planned, so will happen. Okay, so I guess most of CD markers इसमें revision classes में नहीं include होगा. CD marker has become a monthly ritual, guys. CD markers, so anyway, every week also if we read, we forget na. So we've decided that till the exam, we'll do 2 more revisions of CD markers. One revision we'll do end of April, then one revision we'll do right before the exam. So CD markers automatically yaad ho jayenge. So rather than worrying about it, just do one half an hour revision every month and we'll be sorted. So end of April, I'll have another one of these YouTube classes only and we'll have one of the CD marker revision sessions, right? Okay, so correct. Okay, so we are sorted with today's class. I'll be meeting you all tomorrow and yes, I hope everyone's okay with it. I'll also post the links for the next class. Next revision class will now be on 16th. So the YouTube series ki baat kare agar, so the next revision class of YouTube will be on 16th, which is a Saturday, and timing will be remaining the same, that is 4 o'clock. Okay. Thank you so much, guys, and see you all in the next class. Meanwhile, see you all in the Kickstart morning sessions like we meet anyway every day. So that is all ongoing. Plus class students, 2 batches coming up this month. FMGK plus class students, the 2 classes for you are on 14th and 15th of April. Whereas when I'm talking about the NEET PG students, the plus classes for you guys are on 29th and 30th of April. So please keep note of these, and they're already there on the calendar on the app, so you should be able to pick it up from there as well. Okay, thank you guys. Thank you so much. Study well and just study the way we've been doing it right now. Try to correlate, try to pick up all collateral miscellaneous questions. Don't just focus on one MCQ, one topic. Try to revise the entire topic and everything associated with it so that you have more of, a consolidated kind of a revision going on. Okay? Thank you so much for joining.